I think that we can go ahead and start. I think we're live. So good evening.
Okay.
Hello. It is just wonderful to see you all here tonight. Welcome to Ask Me Anything with Dr. Sue Levine. Thank you for waiting. Sorry, we were having technical difficulties. We do have Dr. Levine with us, but it will be audio only. Ask Me Anything with Susan Levine is hosted by Body Politic through its global network of COVID-19 patients, chronic illness allies, and health and disability advocates. Body Politic continues to break down barriers to patient-driven, whole person care and well-being, particularly for marginalized communities, by facilitating peer support, cultivating patient-led research and public education, and as a leader in community-based advocacy. I'm Dr. Leigh Jerome, a New York-based clinical psychology with expertise in intersectional collaboration, art, culture, and behavior change, pathology, psychophysiology, empathy, and women's issues. I'm also a mixed media and installation artist and founder and CEO of Relational Space, a nonprofit gallery in New York that facilitates collaboration between artists, scientists, policymakers, and activists to co-curate immersive installations with evidence-based narratives that promote social change. You may be familiar with our recent VR exhibition, Long COVID, We Are Here. It is now my honor to introduce and welcome, with my own personal heartfelt gratitude, Dr. Sue Levine. Susan Levine M.D. graduated from Albert Einstein School of Medicine in 1981 and completed a residency in internal medicine at Montefiore Hospital in the Bronx, followed by 2 fellowships, one in infectious diseases at Memorial Sloan Kettering Cancer Center, and allergy and immunology at Mount Sinai Hospital. During her second fellowship, while working with Dr. Charlotte Cunningham-Rundles, one of the co-authors of the original case definition of ME/CFS, Dr. Levine became intrigued with seeing her first few CFS patients who were seeking a diagnosis. She examined natural killer cell function and abnormalities in catecholamine response in these patients, and then opened a private practice to provide medical support to the growing CFS population in the New York and New Jersey area. Over the last 2 decades, Dr. Levine has collaborated with renowned clinicians and researchers, co-authored a manual for physicians that is a primer for internists about the care of CFS patients, and is currently serving on the Federal Advisory Committee for CFS. She remains committed to seeking better treatment for ME/CFS and long COVID patients, and to collaborating with like-minded scientists to gain a better understanding of these illnesses. With that, I'll turn the podium over to our esteemed guest, Dr. Sue Levine. Welcome, Dr. Levine.
Oh, thank you. Thank you for that wonderful introduction, Leigh. I so appreciate your help and support over the last couple of years. And I also want to thank Body Politic for inviting me here as a guest speaker. I think your organization is absolutely stupendous. I always refer patients who don't already know about it to your website, and I'm so impressed with the data collection and the professionalism of it and all the information that you have. Anyway, let me launch straight in, as I already wasted enough time with my technical non-expertise. And I want to go through briefly the case definition for ME/CFS. Okay, it's quick. It's the most consolidated version. So for someone to be labeled with the diagnosis of chronic fatigue syndrome, aka myalgic encephalomyelitis, one has to have had 6 months of fairly severe exhaustion, or what is known as post-exertional malaise. Some of you are familiar with that term. What it refers to is doing just a little too much on one day, perhaps eating dinner with friends or going to a movie, and then the next day just absolutely crashing. That's number one hallmark of ME/CFS. Unrefreshing sleep, even though one has slept through the night, feeling as if one had not. and cognitive abnormalities, including like brain fog, as it's known colloquially, or symptoms of dysautonomia, which includes orthostatic intolerance or feeling like you're going to pass out, the rapid heart rate, temperature dysregulation, etc. Now, the reason I kind of wanted to mention that is there are obvious parallels with what we are calling long COVID, in the sense that many patients have similar symptoms. And what I'm going to do is just compare and contrast these two entities. So we have now the case definition for non-COVID ME/CFS. Long COVID is, I think it's still in the process of being completely defined, and perhaps it's slightly more heterogeneous in nature. Not all long COVID leads into ME/CFS. And in fact, I would argue that the time it takes to become a quote unquote long hauler is probably less. I think you can call yourself a long hauler if you've had 4 to 6 weeks of these persistent symptoms following a COVID infection. But again, you may not meet the criteria for ME/CFS. You may have, for instance, fatigue alone as a standalone symptom, shortness of breath, or a number of other symptoms, palpitations, pain, sleep disturbances. But like I said, we're finding that a number of patients feel terrible. They feel really sick, but they may not necessarily have post-COVID ME/CFS. But then there are those that do, and if they meet the criteria, I try to classify them as such. So we try to go through the laundry list of symptoms, checking off which ones people have when they come into the office or when we evaluate them in a research study. And as I said, that's still kind of a work in progress, because I suspect there will be many heterogeneous subgroups under the heading of long COVID. The other differences between the two conditions include usually more often than not some kind of end organ damage in long COVID. For instance, myocarditis, some residual lung issues, even in the non-hospitalized patients, and some neurological findings. We don't see that as clear-cut in non-COVID ME/CFS patients. I think the flu-like symptoms, although some long COVID patients have them, I'm talking about sore throats or gland swelling, don't occur quite as often as in the ME/CFS population. And although there are many other things we could discuss relating to this, the other key feature that I'm going to talk about a little bit in the next section is coagulopathy, because it offers an avenue or target for potential treatment, as many of you know. So microclotting has been investigated more often in the hospitalized COVID patients, but it's clear that the long haulers who have not been hospitalized but who are still very ill may well harbor microclots. And these are quite difficult to detect without special studies. People are now using nuclear medicine studies to look at these, meaning tagged red blood cells, and watching where they go in the individual's blood vessels. That sounds complicated, right? It's pretty invasive. What I'm doing and other practitioners are doing in the office are some blood tests to look at levels of procoagulant factors in the blood, and then trying to determine whether those indeed are putting that patient at risk for microclotting. The reason it's important to find this out sooner rather than later is you want to break up the clots, if there are any, because as they accumulate, it causes diminished blood flow to vital organs that then further exacerbate the already bad enough symptoms of this illness. So I think this offers a very promising avenue, and I'll speak more about it later. The other interesting thing, sort of parallel, I would say, between long COVID and ME/CFS is the occurrence of certain comorbid disorders. In other words, POTS, postural orthostatic tachycardia syndrome. And there are, again, many varieties of that, of general dysautonomia. And the way I explain it to patients is a disconnect between blood pressure and pulse changes with changes in position. So normally your blood pressure rises slightly and your pulse goes up slightly when you go from sitting to standing. Well, this is much exaggerated and may go in opposite directions in both ME/CFS patients and long COVID, and thus leading to POTS and orthostatic intolerance. And again, not getting enough blood flow to vital organs if your heart rate is too fast and your blood pressure is too low, because it's just not getting, the blood volume isn't circulating adequately, basically. And I think that's another area that should be addressed right away when one identifies it in the long COVID patient, because it can really relieve a lot of the symptoms of fatigue and reduce the palpitations and the chest discomfort. Other important comorbidities I'll mention are mast cell activation syndrome, which is an excess of histamine and other type of mediator release from mast cells, both in the brain, in the gut, and in the bladder. Typically, people associate mast cells with allergies, but histamine can also cause pain and sleep issues. So reducing mast cell burden is important in both long COVID and ME/CFS. And last but not least is neuropathy. And neuropathy involves damage to the central nervous system by a hyperactivated immune system, which we think is at work probably both in long COVID and in ME/CFS patients, where simply that person's immune system, I'm putting it simplistically, gets turned on and the off switch just isn't working. So there's an excess of inflammatory cytokines known as cytokine storm, more again in the post-ventilator COVID patients, but also in the long haulers. There's like a constant low-level cytokine storm occurring. Okay, now I looked over a lot of the questions that I received, and obviously many of you want to know about treatments. I think the most promising in a big way, but also the most sort of complicated and potentially distressing target, it would be the coagulopathy. So how do we assess this coagulopathy, and to what degree is that occurring in the individual patient? I mentioned this invasive nuclear medicine study, which unfortunately is not available to the average long hauler. It's only being done at NYU, as far as I know, and only 10 or so patients are allowed to do it at a time. Alternatively, one can order a battery of blood tests and looking for not just D-dimer, but factor VIII, von Willebrand factor, and plasminogen activator inhibitor. There are a number of these. I've gotten a whole lesson in hematology since I've started dealing with long COVID. I mean, I'm infectious disease, and so we don't really know much about, that's a different silo, hematology. But I've had to take a quick lesson in learning all about, clotting factors and platelet aggregation. So anyway, if an individual has a reasonable number of these clotting factors elevated or abnormal, I think it's not unreasonable to think about aspirin therapy or something reasonably benign. Now, there are studies going on internationally. I researched this also for this talk, and apparently people are using different combinations of not only safe, quote unquote, safer things like aspirin and even Plavix or clopidogrel, which is used in strokes, but even low doses of heparin and other oral anticoagulants. I think this should be done probably in a research study if you're going to go anything beyond aspirin or Plavix, or should be done in a hospital setting and at least with a trained hematologist. That's another story, trying to get other specialists on board to help us with some of these studies. It's been a bit of an uphill battle, but I think that's certainly an area that we need to address some gaps in specialist care, and this is kind of an example of it. Nevertheless, I think addressing potential coagulation defects in this population is very important and could yield some promising results. And again, one wants to strike early before the patient develops too many of these clots. The endothelial surface, I'll try not to get too esoteric here, of blood vessels, as you may know, is where COVID adheres, because that's where the ACE receptors are. And that's why emboli and clotting formation is such a thing, particularly in COVID patients. The other ripe area for targeting research and treatment, as I mentioned earlier, is addressing the mast cell instability. Many patients go through blood tests and measure histamine and tryptase levels. And that's the easiest thing for doctors to do, is to just do a simple blood test. However, and I always tell patients this, even if their histamine and tryptase levels are normal in the blood, that does not mean that they don't have active mast cells in the gut, in the brain, or in other organs. I do believe that mast cells are still active in 90% of long COVID patients. There's been studies on this. The problem, once again, is that we don't have access as clinicians to the gut, doing a biopsy on the epithelium in the gut and staining for mast cells. But if we did, we would find them there. As clinicians, we mostly can do blood tests, and unfortunately the answer to a lot of the underlying mechanisms that lead to long COVID are not always found in the blood. And examples of medications to try patients on, many of you already know, ketotifen, high-dose famotidine, Allegra. I'll also mention low-dose naltrexone here. LVN does stabilize mast cells, and it's a handy treatment for a lot of patients who seem to tolerate it quite well. You may have to play around with titrating the dose a little bit depending on the individual. I'll just go through a few more of these. You can let me know, how much more time I have, but I'll just run through the rest of these.
You have all the time you want, Dr. Levine.
What was that?
I said you have all the time that you want. You let us know when you're ready for questions.
Oh, okay. Another area, and I'm going to try to explain this properly because even I had trouble understanding this, but I think it's fascinating. There is a long COVID coalition group, and they just sponsored a conference, and it brought together people from all over the world, Italy, the UK, and here from the US too. And one of the more fascinating speakers was a doctor from Italy. Let me see if I don't mess up his name, Dr. Crogna, Dr. Brogna, Brogna, Carlo Brogna. And he and others before him have published on this phenomenon of the bacteriophage. Now, why does COVID perpetuate? Why do we have long COVID? Well, we think after a certain period of time, these viruses are gone, they're eradicated. But it turns out that in some long COVID patients, and probably in other chronic viral illnesses, the virus or particles of the virus take up residence in the gut microbiota. In other words, they set up house in your gut, in the bacteria of your microbiome, and they usurp the bacteria of the gut's replicating machinery, and they become factories for more COVID particles and for these things called peptide toxins, which can alter brain function and cause other harm in terms of functioning of the immune system and other areas. But the key thing is altering brain function. So what he has done, Dr. Brogna, is done a study where he's used a combination of antibiotics, Xifaxan and Augmentin in particular. And he's tested numerous combinations, and this combination seems to be the most potent to eradicate this gut bacteria that presumably is housing these toxins. And he's done all sorts of fancy experiments to prove his case. In other words, he's taking the supernatants or the liquid from the gut bacteria of COVID patients and infected non-COVID infected patients' gut bacteria, and managed to do it. So he's able, just by using the peptide product from these gut bacteria, the gut cells, he's able to induce a COVID-like illness in non-COVID infected cells. So the point is that it's sort of spooky how it's not just the virus itself that can exert a lasting effect, but the products of these viruses that may contribute to long haul COVID. And we need to really learn more about this so we can stop it, soon, early on, before it replicates and it's harder to halt. We learned that lesson in non-COVID ME/CFS. Too many people have gone for years without treatment. So the whole idea is to strike early while the iron is hot, when you can recognize this whole phenomenon very early on. So there's a lot of other interesting sidelights to this gut microbiota story, and again, how it can alter brain function and possibly affect learning and other things in subtle ways. So anyway, sorry I got carried away on that one, but I thought that was interesting. And then other treatments that are, I'm sure, known by many of you are treating the POTS, and that usually gets done with either the use of beta blockers, drugs like propranolol or metoprolol, Florinef, which allows the body to reabsorb sodium so that the blood pressure goes up, and Corlinor and Mestinon. And there are cardiologists in the city here in New York are reasonably familiar with how to use these medications. So the POTS and the mast cell treatments, I think, are kind of no-brainers to start patients on early on. The other one that I'd like to address, the other comorbidity, is the small fiber neuropathy that a number of patients have, where if one does a biopsy of the skin, one finds disordered nerve fibers, and that is treated with gamma globulin. That may not appear right away. That may appear a little bit later down the road. But anyway, I encourage patients, if they're able to see a neurologist familiar with long haul COVID. Paxlovid has been talked about and asked about by a lot of my patients as a treatment for long haul COVID. Part of the problem is knowing what the dose would be. For instance, how many courses would a patient need, how to spread it out. We have treated a few patients with Paxlovid, and it's really hard to know whether it's had any benefit at all, because as you know, right now it's approved for acute cases of COVID. I'm almost done. I want to make a brief mention about the effects of vaccines, especially boosters, on long haul patients. There were some reports initially that some patients fared better, improved after getting the vaccine. But and lately I've had a number of patients either have some adverse side effects to particularly the second booster. So one has to watch out for this. I'm not saying don't take it. You need to really take care of yourself. So what I think is wise to do is to have your doctor order a neutralizing antibody titer. In other words, to see what your COVID antibody levels are before you take the second booster. If they're already reasonably high, you may be able to wait a little bit longer and possibly receive some kind of pre-treatment before you get, like to prevent an adverse reaction before you get the booster. It's just another thing that we've noticed with some adverse reactions to certain things, like these vaccines. Okay, Leigh, I think I'll stop there and entertain any questions. You still there?
Sorry, I was having trouble with my mute. Can you hear me now?
Yes, yes.
Okay.
Uh-huh.
Yeah. So that was just such a terrific overview, really fascinating. You covered a lot of the things that I know people are interested in, and I'm sure you'll go into a little bit more detail with some of the questions, but thank you. It was really just a terrific overview.
Oh, thank you. Thank you. Yeah.
Yeah, so okay, so we'll move now to the question and answer period of this event. Let me remind the audience that Dr. Levine cannot provide individualized medical advice, and to please keep your questions relevant to the presentation topic. We'll get to as many as we can. Just a couple of notes. One is that there's several questions pertaining to specific therapeutics, several you've touched on. Most of the questions also have two parts, Dr. Levine, so just so you know.
Okay.
Okay, so the first question is, and you did address this, I know, just now with the Paxlovid and the Augmentin, and I forget what the other one was.
Xifaxan, yeah.
That's it, yeah, Xifaxan, yeah.
Yeah.
But are there new drugs? So the question is, are there new drugs that you're planning to use off-label to treat long COVID? And this is referring to new drugs that are either being researched or coming down the pipeline that you might potentially be using in the future that are not already available. And if you feel you've already answered this, you could just say you feel you've already answered it. I was just wondering if there's anything else. Mm-hmm.
Yeah. Well, and just as I told you, I was going to close my remarks, and I still felt like I talked long enough, but there is so much to talk about. I didn't mention, and this is not exactly what you're asking, but that COVID can reactivate other viruses that are previously dormant in the body. And again, many of you know this already, Epstein-Barr virus being one of them, human herpes 6, and probably many others. So another, I would say, ancillary treatment would be the use of anti-herpes agents like Valtrex and Valcite. So I think that's kind of important to mention as well. What the other thing, I think there will be other treatments, not only this combination that I just mentioned, the Augmentin and the Xifaxan, but even though that's the best treatment, there are people who are allergic to penicillin and can't do Augmentin, which is a derivative of penicillin. So there will be other antibiotic combinations, I believe, that will be tried. I also think that, and again, I didn't mention this, but many of you know that I'm looking at metabolic changes, and people have been starting to look at cholesterol rising precipitously, as well as insulin resistance. Metabolic changes, very interesting. The body goes into hibernation mode. It's trying to preserve energy. So people have trouble losing weight, even though you're sedentary. People, and that's the least of your problems, but I'm just saying that it manifests as that, an ability to lose weight or gaining weight, and high cholesterol, which could put you at risk for heart disease. So we're looking at these abnormal lipid levels as inflammatory also and contributing to symptoms. So cholesterol lowering drugs, which you might not think of as anything that would really help fatigue, but it might, and brain fog, and drugs which I know are already being used, like metformin and other drugs that alter metabolism, I think are going to be studied more closely, and perhaps other drugs that affect the adrenal pituitary axis. One area, and I came across this in my research of what's kind of ongoing around the world, is thyroid and adrenal function. Nobody has really looked at that in a deep way, how that's altered in long COVID, but there are some people that are starting to look at that, and I think there will be some interventions having to do with adrenal hormones and so on. Anyway, I think there will be a lot going on in the next few years.
It's really interesting, and I think it really does speak to the systemic nature of long COVID, how it is, just affecting systems individually, but also on a much larger level. So that's really interesting. And I think that it's interesting to think about things that, like metabolism, makes complete sense that would be something that we'll be looking at. So I know that people, and you did mention this already, you talked about LDN, and certainly a lot of people are using LDN. There's a question that people are interested in knowing what results you're seeing, what you kind of expect to see, and how people might find access to a prescription, which sounds like people are having difficulty finding access.
Oh, access to the LD. Yeah, well, interestingly, for years with treating non-COVID ME/CFS, we had mostly focused on using very low dose naltrexone at a dosing schedule of once a day. And it's one of those drugs that your doctor would have to get usually from a compounding pharmacy. I say usually because there's some patients that actually get the full pill and grind it up themselves at home, but that's hard. It's a little hard to do. But anyway, there are compounding pharmacies. Yeah, there are compounding pharmacies out there. So what I now do is I dose it more often than not in the long haul COVID people twice a day, usually 8 hours apart, and I find that more effective. And I sometimes will change the dose a little bit, but I keep people at the same dose for like 6 weeks or so, right, and then change it ever so slightly. I find that changing doses of meds too abruptly can cause a problem, which I guess would seem obvious, but seems more pronounced in the long COVID people. Yeah, I mean, I think in some people it is a miraculous effect on sleep and pain. In other people, they don't really notice it that much, but I think it's benign enough to just try it and stay with it for a while. You know what I mean?
Yeah, and there's
sometimes it's very hard to know what yeah, go ahead.
Oh, I'm sorry. I was just saying, there's research that says that it reduces systemic inflammation as well.
Yes, yes. I believe it does. I guess what I'm saying, it may be subtle. You may not really notice it,
right?
But I do believe that it does lower systemic inflammation. That one, and I'll just mention a couple others that I think were in a group of questions. Supplements like coenzyme Q10, quercetin, phosphatidylserine is another one I use. And then some of the mast cell stabilizers will also lower inflammation, like ketotifen. And lastly, NSAIDs, even aspirin or meloxicam, which I like to use because it's easier on the stomach. So there are a number of these, aside from LDN, that are helpful. Sometimes I use more than one, like LDN plus meloxicam, for instance.
And you mentioned NAD and CoQ10. Are those targeting fatigue, or are they just more generally targeting inflammation?
Well, they're kind of intertwined. Some can argue that fatigue and inflammation inflammation can drive or cause some fatigue, especially because pain, lack of sleep, and brain fog can lead to fatigue. So it's hard to tease them apart in a way. Right. So I think, they have some, they do exert some effect on that, on fatigue as well.
Okay, that makes a lot of sense, because obviously if you have inflammation, you're much more likely to have fatigue. So that totally makes sense.
Mm-hmm.
Okay. Moving on, you treat a lot of individuals with long COVID. Could you characterize what you've seen as the overall enduring impact of long COVID on the individual? And what is the progression of the illness as you have seen it?
Right. There are different scenarios. I was trying to wrap my head around that a little bit. And, this may not be true. This just may be my perception of it because, as I said before, and you said in your introduction, actually, I've been doing this for 30 years, not 20. I can't believe it myself. But anyway, the point is that, how when you're doing it so much day in and day out, you don't sort of realize, you don't sort of stand back from the situation.
Sure.
It occurred to me that because long COVID is sort of a new entity for me, yet so familiar in a sad way, that standing in the midst of it right now as people are getting sick at the very beginning, it's so dramatic, and I forget that must have been how I felt 30 years ago when I saw my first few ME/CFS patients. So it seems to me that the long COVID people get hit harder, at least right away. I mean, everything happens sort of dramatically. They don't just get a little sick, they get very ill kind of right away. And then sometimes there's a period of let up. Like I find that people like start to feel better. Maybe they can return to work part-time or something like that. And then sometimes they take it too far. I mean, not in every case, but like, let's say they start to feel better and they sort of make up for lost time and start doing things. And then they have that crash, inevitably, unfortunately. And so it still feels sad to me that I see them going through it now, whereas all my ME/CFS patients have already been at that point for years and years. And I hate to say it, but not that they're used to it, but I see these new people going from, lives of whether in school or just starting a new career or, whatever they're involved in doing, suddenly not being able to do it at all. And that tremendous loss emotionally and physically, just really is very sad to me. And, feel a little helpless in the face of that. And we want to do what I can to help. So it's hard to, I'm just trying to put it in perspective from my point of view.
Sure, of course.
But I also see my lessons that I've learned to strike early, to really try to get other doctors, like a team involved, a team of specialists, because that's so importantly. I mean, I feel out of my league in this hematology thing. I'd love to have other doctors on board to help me out because I don't know everything about all the different specialties that this illness affects: gastro, cardiology, neurology.
Yeah, my opinion about this. Yeah, I agree with you 100% there that we need a one-stop shop like HIV has been able to work out, where there's a clinic and you have a treatment team and there's continuity of care. Absolutely.
Yes, and we can all learn from each other and have like grand rounds to discuss individual patients and inform each other. It would be so good for both the patients and for us as professionals and, care team. But anyway,
absolutely.
Sorry, I could go on. Yeah.
Oh, no, absolutely. Yeah. It's a topic that's near and dear to me. I definitely understand. And that would be amazing in terms of the progress we could make, I think. I want to stay with this idea a little bit of the kind of the progression of the illness. You've been involved in CFS research for 3 decades and long COVID since its onset. So I guess people are really interested, trying to tease apart, like, where is this going? Am I going to be like this the rest of my life? Is this ME/CFS? At what point does it become ME/CFS? Or are they completely separate? Where do those overlaps happen? Yeah.
Right. Well, as I tried to convey, and maybe not very well in the beginning of my talk, I feel that, and I have a few people in mind that I just saw the last couple of weeks, that some of the patients clearly are disabled or not in the place they used to be from getting COVID, yet they don't have all those symptom criteria that you're supposed to have have ME/CFS. In other words, they don't have the level of fatigue, sleep issues, and cognitive complaints. Maybe they have one of those things, like just the fatigue. I have a number of people who can get through their workday, but then they can't exercise at all. If they try even to like walk up a flight of stairs, it's like they crash or they feel really terrible for a few days. So in that sense, but then I have some people who got COVID and then do get ME/CFS. So in other words, you can have a variety of outcomes after COVID, and really try to figure out how to predict that. I really feel, this is going to sound so depressing, that at this point we don't have a cure, that even if some of the patients are able to work and maybe even walk the dog or do some exercise, that they're not really back at their old level yet. Like, I don't know, especially with, talking about this toxic peptide that's secreted in the gut. It's in your body, and even the autopsies, which I know sounds morbid, that they performed on people who passed away with long COVID, they find viral particles embedded in the nervous system and thyroid gland. That's why I mentioned the hormone, the endocrine system hasn't really been looked at. But anyway, but they're finding evidence in all the organs of residual RNA from the COVID virus. So I feel like it literally doesn't leave you, even if you feel maybe 80 or 90% of your old self in some cases. So I know that's not the greatest answer. I just
No. It's really, I mean, you're doing a great job. It's so enlightening. And
I think the other thing to keep in mind, which seems so obvious, is sometimes this used to happen to me. I used to laugh about it in the CFS population. Some of those people who are like really back to their old selves, they're lost to follow up. They don't bother going back to them. So I don't know what's happened to my patients who've recovered because they don't bother going. But I think that's another thing we should all plan on doing is reach. And before we hang up, I want to make a plea because we have several studies that we have in the works that are applying for funding through NIH. And I'm working with Ian Lipkin at Columbia and Maureen Hansen at Cornell to try to fund some studies. So I'll need a lot of you folks as volunteers, but I'm hoping to have a continuity of following patients even when they get better, in their view, get better. Do you know what I mean? So that
absolutely
so people are not lost to follow up. We really get a whole 10 years afterwards what happens to patients, like a more,
Definitely, I agree with you. We see the same thing in Body Politic. When people get well, they leave, understandably, but it does make you wonder about, what the long-term experience, especially if the neurologic symptoms, there's so many neurological symptoms. Yeah. And we don't know. Right.
It can be very subtle and stuff like that. Yeah. But I mean, we really need more people on board, multidisciplinary approach, and people recognizing it earlier and so forth. And a lot of the other issues that I know you're involved with, like disability and advocacy and mental health and stuff like that, is necessary.
Well, you've hit on so many things. I know we're a little bit over. I'm going to go ahead and just, if it's okay with you, just go ahead and ask another question here. You've talked about microclots. You've talked about viral persistence is what you were just speaking of, regardless of how we're feeling, it feels like it's still there. So it sounds like you feel and then there's the microbiome and, the vagus nerves. There's so many different things going on. So I'm wondering if you feel like it's a combination of things versus a single, and then curious again. I'm sorry, I'm just looking at this question. I guess that's just what I would ask. Do you feel like it's a combination of things rather than a single thing that's causing long COVID?
I really do. And I feel even in those people that just have the one or two major symptoms, maybe don't meet the case criteria for chronic fatigue syndrome, I still feel that they need to be fully investigated for POTS, mast cell, because I think a lot of these, triggers or these symptoms may be under the radar, or a lot of the laboratory findings are there, but even if they don't display symptoms of mast cell, for instance, they may still have elevated histamine levels, or they may have signs of inflammation. And so you want to kind of identify them early on. Yes, it is. I think it's very complex. I think, the gut bacteria, the microbiome, metabolic implications, and dysautonomia, hypothalamic pituitary axis, neurotransmitter cognition, it's all intertwined. And it really requires a multidisciplinary approach, sort of beyond what we really have available to us. I think there's a lot of research going on in laboratories around the world. I feel that there's not enough in-depth care for patients that really takes it to a high level in each individual patient, and obviously not access, except in cities like, New York, and where people have health insurance and so forth. And not everybody has health insurance here. I didn't mean to imply that. But, there are places, and we found this with ME/CFS too, there's no place in the Midwest that there's no doctor in Chicago, for instance, or Illinois that is familiar with a lot of these illnesses. It's not taught in medical schools. It's, so there's, and then if you go to a rural clinic, I don't mean to be stereotypical, but it's really the big cities that have some knowledge of it. But can you imagine, those people who don't have access to care? Yeah. And in other cities or in rural areas, with a doctor is also pretty harried and has huge patient loads.
And like you said, it takes a team. Yeah, it takes a team. I mean, if you have one person that gets it, and they have to send out referrals to, 5 other people who
Right.
don't get it, then the person's not really going to be able to receive the care they need.
Right. Yeah. So it has a lot of social implications. It's political. Yeah.
Right. It is indeed. I'm going to just throw out a couple of questions real fast. What's your opinion on Miravac for long COVID? Do you have an opinion on Miravac?
What?
Miravac?
Oh, okay. Yeah, Maravaric. Okay.
Maravaric,
Yes.
sorry.
Yeah. Yeah. I mean, I think there's some interest. I mean, I think it's a CRX5 inhibitor, and I think it's worth. I think a clinical. I mean, I've had some people try it, obviously, through Bruce Patterson and others, and part of the problem is knowing again the right. Same thing with the clotting, the anticoagulation protocols. I always wonder, like, how do people figure out the duration of that particular treatment and what the right dosing schedule is.
Right.
The problem with Maravaric is that it has could have side effects, and you have to be monitored pretty closely, and it's not always covered by insurance. So it's one of these things that you want to maybe try for a limited period of time, but then you don't want to stop it if it could be doing something if you were on it for 3 months instead of just 6 weeks.
Gotcha.
You know what I mean?
Uh-huh.
So I think it's a promising, to answer your question better, I think it is a promising area, but it's still not quite there yet.
Gotcha. I'm going to have one last question and then we'll end for the evening. And thank you for sticking with us. So what are your thoughts on around the role of a super antigen in COVID as it relates to long COVID? Do you have any thoughts about that?
Yeah, I mean, I think there are parts of long COVID, particularly, you mean like what's triggering it, or the part of the virus that's, probably the spike protein.
That's what I'm reading. Yeah. Uh-huh.
Yeah. I mean, I think, again, that's what attaches to these different cells in our body or in the body of people with long haul, like the endothelial cells I mentioned earlier in the blood vessels, and the brain too has targets for this spike protein. So I think in some ways it could be used therapeutically, potentially, maybe given in small doses, kind of like a vaccine effect.
Interesting.
Yeah.
Okay. Do you have any closing remarks or things that you feel like we didn't get to that you'd like to?
I guess I sort of touched on it. I mean, I think, again, the biggest thing I see in my world is a lack of interest, or not an interest, I guess. I mean, I don't know for sure if it's interest, but just a big gap in care in these different specialties that I think are intertwined with care for long COVID people. I mean, I think there are reasonably adequate resources for cardiology, for instance, and neurology, but not so much for gastro, endocrine, and hematology, which I think are going to be big players. And by endo, too, by the way, I mean, I know most people think of it as a cardiac thing, but like this lipid, the high cholesterol things, even cardiologists don't know much about how to treat the high lipid levels in long COVID people. So, I mean, I guess I would address the big gap in specialist care or involvement. And then the last other thing, which we didn't really touch on, people always ask me, is should they exercise and how much? And the lack of just like day-to-day basic advice for people on how much, if any, exercise should they do, and like diet, things like this very basic stuff. Should there be any change? Those are things that interest me because they're just like your basic things,
Right.
And when you go out, when you feel slightly better, is it okay to go for a walk, or you're doing yourself harm? That kind of stuff. Right. I think that kind of, because it's patients care about that, and you need to keep your head on. You need to stay in a good frame of mind while we're trying to figure out the answers.
We've had a couple of other questions. I wanted to, well, first of all, let me just respond to that. I think that it is very interesting, the idea of, pacing and what's really happening when you're trying to build up and like you said before, like, can you build up? Does pacing actually work? Does,
Right.
or are you just kind of,
I really don't push the exercise angle very much on people. People walk, they're so sick and you don't even want to say the exercise word, But on the other hand, when you, like a year into it, you're in your home and you're isolated and, even a walk to the park may seem like a lot, but on the other hand, it may be helpful for your endorphins and then you don't want the person to get deconditioned either. But usually the choices available now are, I think, too extreme for the average patient. I mean, most of the rehab programs, I think, go a little too far in the patients to quit or they get worse. Yeah. Not in every case, but, I think somebody should be really working on customized, some kind of, body movement program for the patient. And maybe also, some dietary suggestions. There are some out there, like the low FODMAP diet. It's hard to keep that up. I think something alternating, like quote unquote regular food with something a little more restrictive.
Okay.
I mean, just your day-to-day functioning stuff.
Sure, of course. If you wouldn't mind sticking with it a little bit longer, we have some questions that have been sent live. Okay, great. So one is response to your discussion about microclots, and there are two questions about this. One is, do you have any advice on how to access microclot testing in the U.S.? I know you had said basically,
difficult. It's difficult.
Difficult, right?
Yeah.
And then the second one is, if you could get a summary, if you, just what the tests are that you would use or that people would request as far as identifying microclots, if they were just using a blood test.
Yeah, I thought about this, and if you like, I'm happy to, you can ask whoever that I can write up some of the things I've written that I think are might have been hard to capture with me just speaking. I'm happy to write up, give a list of those things, for instance, and to maybe enlarge a little bit on the other,
that would be
the
terrific.
Microbiome, if people are interested on the thing. Yeah, I'll give a list. I think part of the problem, and I know Leigh, that sometimes even with these high clotting factors, some hematologists will look skeptically at whether it should be treated or not. And, it's still kind of such a new thing. But I think, to answer the question about how to evaluate clotting, it's so limited. I can't believe that there must be more, but the only one I know about is David Lee at NYU doing, maybe 10 people every few months. He's only getting funding for that amount of people. To us, and mostly those have been on ventilators. So he doesn't do that many long COVID people who, weren't as sick in the beginning. To look at, he's literally looking at clot formation at the cellular level, and it involves like this invasive test, which is probably the best way of looking at it. But there's so few of those available. But yeah, the blood tests I think are a good second best. So I'll provide like a list of those.
That would be so great. Apparently several people have asked for that. So I know that would be really greatly appreciated. Going back to the issue of microclots a little bit, do you believe that microclots accumulate or form and dissolve? And this is related to flares. So during crashes or flares, do you think they're forming and dissolving intermittently during flares? Do you think that they're accumulating?
Well, it's interesting because I thought about this recently. There's a lot of reasons other than, so there's inflammation. When the body sees an infectious agent, your immune system secretes these cytokines, these inflammatory molecules that include factors that promote blood clotting, because it's actually beneficial to have blood clotting so that the person doesn't bleed out. Like in an accident, you don't want the person to bleed out. So that's why nature evolved having a clotting system. But there's an excess of it in long COVID. And so the factors that maintain the clotting situation have to do with genetics in part, that person not having the right breakdown or the product to lyse the clots. So there's these things, I just learned about this myself, protein C and protein S that one measures, and that's on my list. Like if you don't have a high enough amount of protein C or protein S, you can't break down these clots on your own. And so that has to be assessed. And the other thing is, because you're sedentary, because you're feeling lousy, clots occur in stasis. So in other words, if you're not moving your legs or your body because you can't, you're so fatigued and feel crappy, that promotes the lack of movement is a further thing that a hindrance to clot breakdown.
Great.
And there's some other things which I was just reading about, which I found really interesting, that all conspire to, promote clots in the patient, not just the obvious thing of it being part of the immune cycle. So I think it's a really interesting area to explore. The downside is, or the unknown side is, these anticoagulants have side effects, obviously, of their own. Like you could bleed out. You don't want to have that happen.
That's bad.
And that's why you want to engage experts. You want to engage the hematology community.
Right.
So far hasn't been that receptive, or they some of them don't even believe in long COVID, obviously, which is terrible. But you know what I mean? It's not their world.
Right.
So, that's the problem we face here.
Right.
But,
it's about
I
money
think
too.
It's a very interesting area. Yeah. But to me, it's fascinating. I mean, in some place where you can really try to make a difference. But I do believe that they can accumulate because you're going to be staying in one place. You're static. Also, the left, not to get too into this, but the left ventricle, which is part of the heart, also is an area where clots can form. And there's evidence of myocarditis in a lot of the long COVID people, and that means your heart is like a reservoir for clots potentially, because it's inflamed and also may not be, properly filling with blood and ejecting blood, et cetera, et cetera.
Yeah, that's interesting.
That can also contribute. Yeah. So there's a lot of areas. So I think it's really an area that's ripe for, and there are, like I say, all these studies going on worldwide, but nobody has yet come up with the right combination, and there's not enough doctors knowledgeable enough to actually prescribe it or feel comfortable doing that.
Right.
So that's all about that. Yeah.
I just want to make one comment, and then I have another question. It's actually a question, but if you can add it to your list, I think, or to the write-up that you're going to related to.
Right.
Is COVID neutralizing antibody test readily available? And what is it called at Western LabCorp? So
right. Yeah.
If you could just conclude that. Yeah.
Mm-hmm. Yes, it is. Yes, so it's it's both LabCorp and Quest, and it's called a semi-quantitative, because you want a number associated with it. You don't want it to just be positive or negative. That's a qualitative test. So that's it's a COVID neutralizing antibody. I may have it right here, but I'll include it on my list. I'm looking in my little
that would be super
area. Yeah.
And we'll send that to you.
SARS-CoV-2 semi-quantitative total antibody test.
Beautiful.
And both Quest and LabCorp offer that. Now, what's strange to me too is that the number can be pretty, in my mind, kind of high, but still not. So you want a number that's like 20,000 or more. Now, if you have something like 1,500, that still seems like a high number, but that may not be protective enough. So I like to get people into the 20,000 range with that.
Gotcha. That's helpful.
So that'll be the kind of number, that
you're looking for. That's really helpful. Thank you. Is there any information on whether this virus, COVID, is more likely to lead to ME/CFS than other viruses?
That's a good question. I think it could. I think it could. there have been epidemics before, as you know, of other
Right.
coronaviruses like MERS and so forth, but the numbers of people affected were not as large, and so that kind of went unnoticed, like a little blip. I think there were people. Now, we haven't had epidemics, what I call now, and obviously an epidemic of this size since influenza, and back then people weren't interested. But if you really look carefully, which I have, because I'm kind of interested in this area, post-Spanish flu, there were cases of post-influenza chronic fatigue syndrome. And if you look at any of the big outbreaks, there were some, but they kind of fell under the radar because people didn't have the technical knowledge to investigate them. And people were just too worried about like people dying of like bacterial pneumonia. Remember, they didn't have antibiotics until the 40s. And so
they had bigger
a lot
issues.
Of these things, yeah, I mean, so I think a lot of these things, they must have happened in the past. We have some accounts of them sort of buried in the history books, but not many people pay that much attention to it. But on the other hand, I do believe that COVID may be more likely to cause long-term sequelae because of its immunogenicity of the spike protein and its attraction to nerve and blood vessel cells.
Sure.
In other words, it has a stickiness to a lot of organs in the body that other viruses lack and that are maybe more easily cleared out of the body.
Right. If we can't dispel COVID, if it's just remaining persistent in us, then obviously.
Right. Yeah.
Are there any significance to high ACE levels in long COVID? ACE levels in long COVID?
ACE levels? I'm not sure. I haven't measured that so much, so I don't know.
Okay.
Yeah.
That's fine. Is there some relationship that you know of between long COVID and increased exacerbation, increased or exacerbated symptoms in collagen diseases such as EDS?
I'm not sure about that so much, but so one of the things which I didn't really touch on, but one of the things I'm always interested in trying to find out, and I know I do it in kind of a limited way, but are there risk factors for developing long COVID? So I believe that some people who, and they may not even notice it growing up, maybe they did gymnastics or something like that, and then some of those people with hypermobility seem to develop long COVID or even just non-COVID ME/CFS more often than the general population. So I think it lends up, and why that's the case, I'm not sure, but it seems to be more in the background of people who have this. But then there's some people who develop that only after getting COVID. It's a curious thing. Yeah, it's kind of interesting.
Really?
And
that is interesting.
Yeah.
So there seems to be like maybe some link, but we don't know what it is really, if it's a chicken or egg.
Yeah, I mean, some of it may be antibodies or damage to connective tissue and to tendons induced by COVID in terms of the immune system producing cytokines and other inflammatory molecules against soft tissue components, thus leading to hypermobility. And then I've seen a few people with other abnormalities like tethered cord or craniocervical instability, like certain anatomical orthopedic issues that maybe were there in kind of a more latent state pre-COVID. It's very hard to know.
Right.
And then we're just brought out by having gotten it. Yeah.
I'm gonna start to wrap things up here, but let's go see if we can go ahead with maybe one or two other questions. So you had talked about the gut biome. There's a question here about as to whether there's any investigation that would show a link between parasites in the gut and bacteria in the gut of long COVID patients.
Yeah, I mean, I think that's very possible. I think we're just at the very beginning stages of looking at the maldistribution of gut bacteria. In other words, what we've shown in non-COVID ME/CFS in a study I co-authored with Ian Lipkin up at Columbia is that there's too few of the good kind of bacteria in the gut of ME patients versus the the bad kind. So that the good kind is the kind that produces butyrate, which is something that is good for you.
Okay.
And I think, parasites and other viruses in the gut have not been looked at as much, but I suspect that one will find, some like distribution of parasites in the gut as well. Most of it is bacteria, though.
Okay.
The bacteria is really responsible for a lot of the problems there.
Okay, and I'm going to ask you one more question. If someone catches COVID a second time, do you think that they're more likely to get worse, have new long COVID symptoms, or just go back to square one?
Yeah, you know what? It's crazy, but there's an article in the Atlantic online. I was just reading it. Like some people are getting, I know it sounds crazy, like the third, fourth, fifth time. Can you imagine? All these new strains.
Right.
You wonder what that does to, I think it can be damaging. And that's why there's the question of, putting people right away on Paxlovid or some other medication, or even trying this antibiotic combination I mentioned earlier.
Right.
It's crazy. I think there's a chance that you're already pretty vulnerable as it is, and then getting, what's the right thing to do here, in terms of treating it or doing some kind of intervention. But
so
I feel like something should be done. I'm not sure. I think every case is different. But that's a big unanswered question.
Yeah, it is so idiosyncratic, but it does seem that, with different COVID variants, perhaps there are different symptoms that could emerge because it's attacking a different system or something.
I think so. Even though people will always say, oh, this was nothing, it was a sniffle or something like that. You wonder what the long-term consequences are of, if each of these is associated with a toxin, for instance.
Right.
And it could have deeper consequences for the person. So I think those things need to be studied. Yeah.
Okay. Well, I think that you've answered more than your share of questions. Okay. So we're going to go ahead and wrap things up. Again, is there anything that you would like to say?
I just want to thank you for your attention and your kindness in reaching out to me, and the patient community has been very good to me. I'm definitely available to answer questions online, and like I say, we'll try to put out a little summary of things that I think might be helpful or relevant that we touched on.
That would be great.
But yeah.
Well, I want to thank you again, Dr. Levine. I mean, you have just been fabulous in terms of the depth to which you responded to these questions, and you've just so generously given of your time and answering quite a few questions today and sharing your considerable knowledge with us. So thank you so much.
Definitely my pleasure, Leigh. Thank you always for your support, and thank you to the rest of the Body Politic team. I really appreciate it.
Well, on behalf of Body Politic, the grassroots organization at the forefront of the patient-led movement for long COVID, thank you all for joining us wherever you are. And we are an entirely volunteer-run organization made up largely of long COVID patients. So if you would like to support our work, please contribute to our GoFundMe campaign. It'll be linked in the YouTube video description, and you can also find it here in the chat. So thank you again, everyone, for joining us. Thank you, Dr. Levine, and good evening.
Okay, you're very welcome.